Good afternoon. Today we are going to discuss a clinical examination case. Patient name B. Hemcharan Behera, student hailing from Rayaga hilly area, presented with chief complaints of fever since 5 days, headache since 5 days. Patient was apparently normal 5 days back and the present complaint started as high grade fever associated with chills and rigors, intermittent, not associated with any rash, associated with headache which is bilateral, which got relieved on using medication. No history of vomitings or nausea, no history of loose stools, no history of cough, no history of shortness of breath, no history of altered sensorium, no history of neck stiffness, no history of burning micturition. Patient had history of bleeding from gums 2 days back and no history of hematuria or blood in urine. Patient had no history of decreased urine output. Patient had no history of joint pains, no history of chest pain or palpitations, no history of hematemesis and blackish discoloration of stools. Past history. No similar complaints in the past. Patient is not a known case of diabetes, hypertension, TB, asthma, or any seizure disorder. No history of any blood transfusion. Personal history. Patient is non-alcoholic and non-smoker. Takes mixed diet. Has normal sleep and appetite. Has normal bowel and bladder movements. Drug history. No relevant drug history was found. Treatment history. No relevant treatment history was there. On examination, patient is conscious and coherent. Patient has no pallor. He has not icterus. No cyanosis. His peripheral no signs of any peripheral cyanosis. No signs of any clubbing. No lymphadenopathy. That is cervical lymphadenopathy. No signs of any peripheral or generalized edema. Patient's blood pressure is 110 by 70 mm Hg measured in right upper limb in patient sitting position. His pulse rate is 87 bpm, regular in rhythm, normal rate, normal volume, no special character, no radio-radial delay and no radiofemoral delay. His respiratory rate is 17 per minute, abdominothoracic type, regular, and there is no use of any accessory muscles. Patient's temperature is 101 degree Fahrenheit and the patient is febrile. Now let's get into systemic examination. Firstly, we do inspection. Shape is scaphoid, there is no localized or generalized distension and flanks are free. Skin over the abdomen is normal, there is no rash or any red spots. Umbilicus is in midline and centrally placed and it is inverted. All quadrants are moving equally with respiration. There are no dilated veins, visible mass or any visible pulsations or any visible peristalsis seen. There are no scars or sinuses. There is no divergation of recti. Palpation. Firstly, we ask the patient to fold his legs so that the abdomen is relaxed. Now we feel for warmth over the all quadrants of the abdomen. Here there is no local rise of temperature. Next we look out for any tenderness in all quadrants. There is no localized tenderness and there is no guarding or rigidity observed in this patient. Palpation of the liver. Firstly, we start from the right iliac fossa and moving 1 centimeter during expiration, we palpate for liver's border or edge, surface or any tenderness. Here the patient's liver's edge is normal, surface is regular and there is no tenderness. Coming to palpation of spleen, we start from right iliac fossa and we go towards the left upper quadrant. Here the spleen is felt just before the costal margin and it's enlarged in size and the edge is normal, there is no tenderness, surface is regular. Now We palpate the kidneys using bimanual palpation. The right kidney is normal in size and shape. Coming to the left kidney, it is also normal in size and shape. His abdominal girth measurement is 82 centimeters, which is normal and there is no distension. Now we measure from xiphisternum to umbilical distance. Here the distance is 15 centimeters. Now we measure the umbilicus to pubic symphysis distance. It's around 15 centimeters. So the ratio is 1:1. So there is no abdominal distension and there is no shift of umbilicus. The upper segment to lower segment ratio is equal. Therefore, there is no deviation of umbilicus above or downward. Now let's get into percussion. In percussion, we percuss from right intercostal second space from above downwards until we hear a dull note. It corresponds to upper border of liver. To assess the liver span, we continue percussing until we hear a tympanic note and then mark it. Now we measure the distance from upper border to liver border. This is called the liver span. Usually the liver span is less than 13 centimeters. If it's more than 13 centimeters, it means the liver is enlarged. Here the liver span is normal. Now we percuss the spleen using Cassell's method. In this method, we place the patient in supine position, percuss in the lowest left intercostal space and in the anterior axillary line, usually 8th or 9th intercostal space, and we ask the patient to take full inspiration. The space should remain resonant during full inspiration. But here the space is having a dull note, so there is splenomegaly. Now we percuss the spleen using Traub space method. Traub space is a semilunar space in the left anterior chest bounded above by 6th rib, below by left costal margin, laterally by mid-axillary line. With patient in supine position, percuss inferior to lung resonance from medial to lateral. Normally, a tympanic note heard and it is due to gastric air bubble, but here a dull note is heard, so it indicates splenomegaly. As there is no abdominal distension or fluid, we cannot elicit shifting dullness, fluid trill and puddle sign. Now we percuss the spleen using Nixon's method. Firstly, we place the patient in the right lateral decubitus position. Percussion starts at the midpoint of left costal margin and is continued upward perpendicular to the left costal margin. Normally, the level of dullness does not extend further than 8 cm above the costal margin, and splenomegaly is diagnosed if the dullness extends beyond 8 cm. Here, the dullness extended up to 11 cm. So, there is splenomegaly. Now, let's get into auscultation of the abdomen. First, we auscultate bowel sounds over the 4 regions of the abdomen. We should at least check for 3 minutes before we conclude it as no bowel sounds. Here the bowel sounds are present. Next, we check for any venous hum or any bruit. Here there are no bruits or venous hum present. Now we examine for other systems. Cardiovascular system, S1 and S2 heart sounds are heard. There are no additional sounds. For respiratory system, there are normal vesicular breath sounds heard on bilateral side. No adventitious sounds heard. Moving to central nervous system, patient is conscious and coherent and the higher motor functions are normal. Central nervous system, patient's higher mental functions are normal and his GCS is E4, V5 and M6. On summarizing, we have a 25-year-old male patient hailing from Raiga, which is a hilly area, presenting with complaints of fever and headache since 5 days. He also had history of bleeding gums since 2 days. On examination, the patient has splenomegaly and no evidence of other organomegaly, and my provisional diagnosis could be fever with thrombocytopenia due to any infectious cause such as viral or bacterial, and my differential diagnosis are any splenic abscess of infectious cause. As a patient's spleen has no tenderness, we can rule out splenic abscess. And any immunological disorders, as a patient doesn't get involved of any joints and other symptoms, we can rule out immunological disorders. And any sickle cell anemia, the patient didn't complain about any sickling episodes, shortness of breath or any chest pain, so we can rule out sickle cell anemia. And it might be due to any hepatic vein or portal vein obstruction. There is no evidence of any hepatomegaly or any thrombosis of the splenic vein, so we can rule out of these causes. Coming to his laboratory investigations, in complete blood count, his HB is normal, WBC count is normal, but his platelets are 58,000, indicating thrombocytopenia. The liver function test and kidney function test are normal. The complete urine examination of the patient is also normal. We have sent for fever profile. That is, dengue came out to be negative, scrub came out to be negative, but malaria came out to be falciparum positive. To evaluate the abdomen, we have done an ultrasound in which there were features suggestive of moderate splenomegaly. The sickling test came out to be negative, so we rule out sickle cell anemia. So from above all tests, I conclude my diagnosis as fever with thrombocytopenia due to falciparum malaria.
Hi guys, now you guys have seen a good case of splenomegaly. So I will henceforth discuss about what are the important clinical aspects with respect to a patient presenting with splenomegaly. From an examination perspective, an approach to splenomegaly basically starts with a good history followed by a good examination. From a student's perspective, apart from these two steps, the next step, important step, is how you face a Viva VOC. Now, in Viva VOC, questions can vary from history, examination, investigations, and then treatment. Okay, so these are important things that we will be discussing at this point of time. We will be concentrating more on history, examination, and how to summarize, because that is where you initially impress an examiner, and then followed by Viva VOC to see how good you are theoretical about these specific aspects. So first, when it comes to history, there are two ways to see. One, you know it is a splenomegaly case and then you take a history. Okay, that is when you are given a clinical descriptor. Or you take an history and then while examining, if you get splenomegaly clinically, then you go back to history and make sure that you haven't forgotten few specific questions that have been asked. So suppose you have a patient with splenomegaly, history plays a very important role. Okay, so from historical perspective, history. So in history, some points are very important. Now, patient usually comes most of the time with chief complaints of vague, mild abdomen discomfort, mostly on the left upper abdomen. The pain may, if present, may radiate to left shoulder. So, patient usually will present with vague left upper quadrant discomfort or dragging sensation. If pain is present, it may radiate from left upper quadrant to left shoulder. Okay. Then, if at all the patient also has kind of massive splenomegaly, if present, the patient may complain of early satiety because of the splenomegaly pushing the stomach across and reducing its complaints. The patient may also complain of discomfort on lying down or lying on right side. Okay, these are direct splenomegaly related symptoms that the patient may present with. From our side, we have to give importance to few things. One, historically, we should be very careful and take a clear history of the demographic profile of the patient. Demographic profile of the patient, because patient may be in a overcrowded place, or patient, there are some endemic areas, especially that's the reason, endemic areas for some conditions like leishmaniasis, like Kala Azar. Okay, and then that is from history perspective, and also socio-economic status. If it is low and associated with overcrowding, we might have to also think about tuberculosis or other high risk infections. Okay, then once you have taken a specific history, there are a few points, associated symptoms, that will give us clue of what we are dealing with. So associated symptoms. So what I discussed so far was symptoms primarily because of splenomegaly. Associated symptoms, sometimes it can be fever, which could mean are we dealing with any infective causes, or are we dealing with inflammatory causes, or sometimes it could be lymphoma. Second, we should make sure there if there is any features of anemia in the form of dyspnea, or there could be other associated features of hypersplenism in the form of thrombocytopenia and recurrent infections due to low total counts. So we have to see if there are other features of pancytopenia like infections, recurrent infections, or bleeding symptoms. Recurrent infections is because of low total counts, bleeding is because of low platelet counts. Okay, patients may have clear-cut history of portal hypertension, and we will have to ask for history of liver disease. If patient has significant weight loss or constitutional symptoms, you should think of malignancy. Okay, these are important points that you should think of. Patient can also give history sometimes of past or present pancreatitis, which you can probably think that patient has splenic vein thrombosis, which in turn is causing splenomegaly. Okay, these are few clinical things that you should ask. Then patient may even complain of bone pains, which may suggest some form of bone disorder with secondary extra medullary hemopoiesis leading to splenomegaly. So these are important points. Extra medullary hemopoiesis causing splenomegaly. Okay, so these are some associated symptoms that we should be concentrating on. So apart from this, from historical perspective, we are done. Second, what we might have to look at is any past history of TB or any history of lymphoma, leukemia. Past history of TB, lymphoma, or leukemia. Then personal history wise, take a good history of about ethanol, details of which I've already explained in other classes. And is there any history of smoking or tobacco chewing? These can increase the chances of having a predisposition to malignancy. Family history wise, ask for hereditary conditions, because some of the hemolytic anemias can have a hereditary predisposition and even storage disorders. Okay, hemolytic anemia and storage disorders. Okay, great. Next, apart from these symptoms, you should be able to have a clear idea of how to go ahead examining the patient. So now let's talk about the next topic, that is general physical examination. So first, you always, obviously majority of the time, based on different protocol, we usually start with vitals of the patient, right? Vital. So check for pulse rate, BP and JVP. Specifically look for if there any loss of hepatojugular reflux. This will indicate probably we may be dealing with Budd-Chiari syndrome, which in itself can cause splenomegaly also. Okay. Then look at the general facies of the patient. There may be clinical history of frontal or parietal bossing, chipmunk facies, to indicate that there may be blood disorders like thalassemia. Frontal or parietal bossing, there may be chipmunk facies. Okay, then obviously you all are aware of this mnemonic. So please look for Whaler, Terrace, cyanosis, clubbing, lymphadenopathy and pedal edema. Along with this, each point you can also concentrate on other associated points. Among this, what's important is icterus, which can mean to us that there could be chronic liver disease. Lymphadenopathy tells us whether there could be also associated TB or lymphoma. Along with seeing for pedal edema, also see if there is any other features like erythema nodosum, which can mean that we may be dealing with some other conditions like say sarcoidosis. Okay. Now, after this, other important point is anthropometry. See the build, height, weight of the patient, and importantly also see for muscle loss and muscle function. That is, you might have to do tests like mid-arm muscle circumference and hand grip dynamometer. Okay, they will give us a brief assessment. Also look for any features of emaciation. Now this you can mention as features of loss of subcutaneous fat. There could also be features of loss of muscle mass. Okay, so please look into these specific aspects in anthropometry. Apart from this, next will be looking for signs of three important conditions. One is signs of tuberculosis, cutaneous signs of tuberculosis. There could be signs of liver cell failure or chronic liver disease, signs of cutaneous signs of internal malignancy, We'll go in depth about each of these points in a later class, but at this point of time I would want to just explain few important specific points. Some of the cutaneous markers of TB that you can think of are tuberculosis chancre, scrofuloderma, lupus vulgaris. There could be tuberculid being present. So these are few examples of features of TB that you see in a patient. Examples like lupus vulgaris, scrofuloderma, any tuberculids are present. Then we will discuss signs of chronic liver failure that you should look at. There are various features from top to bottom. So there could be loss of hair, there could be loss of eyebrows, mudorosis could be seen, there could be hepatic fetor, there could be parotid enlargement. The patient could have from hand, if you see, there could be palmar erythema, Dupuytren's contracture. The patient can also have gynecomastia. They can have telangiectasias. There could be signs of features of hypogonadism like loss of axillary hair, loss of pubic hair. Patient could have features suggestive of portal hypertension in the form of ascites and pedal edema, which could be seen. If you examine for hepatic encephalopathy, please make sure you do hepatic tremors, look for hepatic tremors. So these are all the features of chronic liver disease. Okay, so you can do a clear head to toe. Please mention all the points. Okay, now there are some features of internal malignancy like acanthosis nigricans, acrokeratosis paraneoplastica. There could be erythema gyratum repens, there could be necrolytic migratory erythema. So there are various other signs of internal malignancy like tylosis, or when there is thickening of skin on the hand. So there are various these causes. So know a list of these cutaneous signs of internal malignancies. Most important will be acanthosis nigricans. Okay, so now that we have seen different features what we usually see in a patient from general examination perspective, now let's go specifically into per abdomen examination. And to be more specific, now we are just seeing how to examine a spleen. Okay, so now let's go into specific examination of spleen. Now, from inspection perspective, spleen is not a visible structure. However, sometimes in massive splenomegaly, it can cause abdomen wall distortion and some asymmetry. Okay, so inspection may not be of great use. Next comes palpation. Okay, now what we should know is spleen is a structure which lies across along the 10th rib posteriorly. Okay, it's adjacent to the stomach and the left colonic flexure, and it also to some extent overlies the upper pole of left kidney. Okay, so in this structure usually, okay, a normal spleen is not palpable. Okay, so what we should know is normal spleen is not palpable. It has to at least enlarge by more than 40% more to become palpable. Okay, these are important points. So from methods of palpation, we have, I would rather divide it as based on what is the position of the patient. So different methods are where the patient is in supine position, or patient you make them get into right lateral decubitus position. Okay.